Hi everyone, I'm Dr. Janina Jeff, staff bioinformatics scientist here at Illumina. And today I have the pleasure of speaking with Dr. Natalie Sweeney. Hi, Dr. Sweeney.
Hi, Janina. Thank you for having me. I am an assistant professor of pediatrics at the University of California, San Diego, and I do my clinical work at Rady Children's Hospital. I am dually trained in neonatology and pediatric cardiology, and also am a physician investigator with the Rady Children's Institute for Genomic Medicine.
Wow, that's a really big title. So I know a lot of your work is on neonates and early life patients, and we always have been talking about genomics and genomic sequencing. Really, when we've sequenced the human genome, one of the things you heard a lot was we should be sequencing every baby at birth. Okay, we've come a long time since the sequencing of the human genome. Can you tell me about a pivotal moment in genomics that really has impacted your work with early life patients?
Absolutely. A pivotal moment for me was when we were able to bring whole genome sequencing in a clinical setting. So I work in the intensive care unit. So I work with critically ill patients where time is of the essence. Once a child comes in, we have limited time to figure out what's going on with them, what the problem is, and how can we take care of these babies best. So when I joined Rady Children's Hospital, I also joined the Rady Children's Institute for Genomic Medicine, and they started doing a research study looking at can we bring whole genome sequencing in a clinical setting. And this went like wildfire. Within 2 months of us starting to implement whole genome sequencing, we were getting diagnosis. At that time, it was within 2 weeks. We were like, this is wonderful. And then lately we can get these diagnoses within 24 hours, 13 to 24 hours. Wow. I think practically 24 to 72 hours, I have a diagnosis. If there's one present, I'm able to tailor how I take care of these infants based on their genetic background. That's been game changing in how we take care of our babies.
Well, we love to hear that at Illumina. So, I would imagine you've probably come across some really pivotal moments. Like you said, being able to have a diagnosis within hours.
Yes.
Do you have a story?
We have so many stories, but I think I will relate this one because I do take care of critically ill neonates, but since I'm also trained in pediatric cardiology, we will also take care of older children. So there was one particular case of a child, it was like a 15-year-old girl, previously healthy, who actually had a cardiac arrest at home. Just right after dinner, passed out. Mom is a nurse, started CPR right away, and at that point called for EMS for transport. EMS came in, they worked on her for the longest time. She was in heart failure, in a horrible heart rhythm that they just couldn't control. So they decided to transport the baby to us at Rady Children's Hospital, where my colleagues in the critical care unit could take care of this child. Because they couldn't control such horrible arrhythmia, they decided to put her on a heart and lung bypass machine just to bypass the cardiac function and give us time to figure out why she had, at 15 years old, had a cardiac arrest. During that, our whole assessment, we frequently, for teenagers, we check for infection because infection can cause the heart to fail.
Really?
And many different infections. And she actually tested positive for one of the viruses that can cause myocarditis, inflammation of the heart, and can lead to heart failure.
Okay.
So while we were doing that and she wasn't really turning around very well, usually when we have a child who has myocarditis, you can put them on a heart and lung bypass machine just to give it time for the virus to run its course, and then hopefully the heart function will come back to normal. Well, with her, it was just such a struggle that they did rapid whole genome sequencing for this child, and within 72 hours, we actually had a diagnosis of a genetic mutation that can actually cause cardiac heart failure. So for us, that was game-changing. Because now we knew that she had a genetic reason for why she had a cardiac failure. So by knowing this, now we knew that this wasn't a waiting game. We weren't going to wait for the infection to run its course and then figuring out if the heart function was going to recover. We knew based on that mutation that is a mutation that can have children show up with sudden cardiac death. By knowing that, we actually put her on the transplant route. She was transplanted within 2 weeks of admission.
Heart transplant.
With a heart transplant,
Wow.
a cardiac transplant, and left our hospital within 22 days without any sequela of her heart failure, back to her normal self, completely back to her normal self. So I think for us, that is game changing. It's game changing that now we didn't have to keep her on this machine for a long time with all the complications. And so that's why we want to limit the amount of time we are on that machine. By having the genetic diagnosis, we knew we needed to get her off of there, but the only way to get her off of that is through a heart transplant. And she did. And that was, whenever we see things like this, if she was at any other institution where you don't have rapid whole genome sequencing, you can send for a panel. You can send and wait and see, and that can take weeks to come back. And during that time, we could have had a catastrophic event.
Yeah.
During that time, she could have had worsening of function of her end organs, like her kidney functions, for example. So I think cases like that stick with me.
It's going to stick with me too. That's a crazy story. That's an amazing story.
Absolutely.
So, in the first question, you mentioned that you're able to make a diagnosis in neonates within hours of life. We have been learning about kind of the clinical findings that we find in germline, but we also know that a lot of these mutations have yet to be characterized. So while there are a lot of people who have diagnosis, there are a lot of people who don't.
Absolutely.
And in some ways, we know that the lack of diversity in a lot of clinical trials and data sets could be part of the reason why that is. So can you talk to me a little bit about, as we improve, as we sequence more individuals and as our data sets and our research becomes more diverse, how is that going to impact early detection through rapid whole genome sequencing?
Okay, that's also a passion of mine. It's to solve variants of unknown significance.
Yes.
And what does it mean? And what does it mean in different populations, which is very important to me. I think right now, for example, I had a very small study where I was looking at just children with congenital heart disease, and I found that there was a higher rate of diagnosis of genetic abnormalities in children who were of Hispanic descent in that group. And so I'm like, why was that? Why is that? Is it because the mother is not getting the same care as their other counterparts, that she's not getting the genetic screening that all the other mothers are getting early on, and this is a surprise afterwards? Or is it because, for whatever reason, there is a predisposition in that area for to be a founder effect, for to be that this variant that can cause a genetic abnormality that we don't know much about. So I think it's imperative that we continue to look in this area, but that we enroll a very diverse population into all of our studies. And I'm looking specifically at that to look at San Diego is pretty diverse. We have a very high Hispanic population. We also have patients from Pacific Islander who come here for care that we can reach, who have different variants. We find different diagnoses in these patients. So why? How come? So I think it's very important going forward for us to continue to enroll diverse populations and then look at these variants of unknown significance that may be responsible for disease. How can we solve them? How can we take this from the clinical side back to the bench, take a look at the expression of these genes in different organisms, and can it inform us about the disease, and can we reach more diagnosis that way by solving variants of unknown significance?
Yeah, because that's ultimately the goal. Hopefully we get at a point where we can use rapid whole genome sequencing to diagnose everyone, and even start to think about one of the things that Barack Obama said that really stuck out to me was that we can shift what we consider this disease-centered care to true healthcare, right? And that's the goal. So I just want to thank you so much for sitting here and sharing all of the wonderful work that you're doing. I'm so happy to hear how transformative whole genome sequencing has been in your work. And thank you for the work that you do.
Well, thank you very much for having me.